The Thyroid Trust, we're a new organisation. We've just quite recently completed our registration with the Charity Commission. But as a group of thyroid patients, we were previously running events such as this in London since 2010. And we were offered funding to create a new charity in 2017 so that we could continue to run those events, which we are doing, but also so that we could start to do more awareness raising and advocacy work, which we've really sort of thrown ourselves into. So because of the terms that we were giving our funding on, and because we feel it's very, very important that people do have an opportunity to come together and hear from speakers such as yourselves, our top priority has always been to improve access to reliable information and quality peer support through our events programme. And then after that, we're absolutely determined to raise the profile and improve understanding of thyroid disease, not just among patients, so although our events are aimed at patients, but also very much among medics and the wider population as well, you know, because there's not as many good thyroid experts as there should be, and there's not as many GPs who really understand thyroid conditions and are sympathetic when they come across a, shall we say, hard to treat thyroid patient as there should be. So, you know, we've positioned ourselves as being for everybody affected by thyroid disease, which includes friends, family, and interested professionals. And the reason friends and family are really important as well as professionals is because when people have a thyroid condition that's not well managed, it can be really, really difficult to advocate for yourself. I mean, I know when I was very ill, I had dementia-like symptoms. You know, I couldn't hang on to the meaning of a sentence from the beginning to the end. I was going to my doctor and trying to talk to them, and tears were just coming out of my eyes, and I probably wasn't being very coherent. So it's really important that the wider public is more aware of typical thyroid symptoms and the fact that they can be resolved if somebody's condition is well managed, so that if they've got somebody at home who just seems, you know, sort of really inexplicably apathetic, as I know my brother was before he was diagnosed, he was on the verge of being sectioned because he was just being really aggressive and grumpy and not sort of doing anything very much. If the wider population were more aware of, oh, that might be a thyroid condition, and, you know, take them and ask about getting that tested and push for the treatment to actually restore their well-being, because that is possible, rather than just accepting, oh well, they're a thyroid patient, therefore they're not going to make much sense and they're not going to do very much to help themselves. We think that's really, really important. So we've taken on quite a big task as a very small new organisation. Obviously, it's been really important to us to connect with other partners as well. So you talked earlier, Brooke, about working with the professional body for neurologists. We, through the British Thyroid Foundation, now have a very good relationship with the British Thyroid Association. So the British Thyroid Foundation is a very established thyroid patient charity. They publish lots of really good information, but they haven't been hugely proactive about awareness raising and advocacy work in the past. And now we're working with them on that, with their support, along with our other partners, which is good. And having the relationship with them has opened the door also to all of the thyroid specialists at the British Thyroid Association, which has been really, really beneficial. We've also connected with other thyroid organisations like Thyroid UK. As I say, Lynn is there from Thyroid UK today, who again have been around and been in this space for a long, long time. And they have a forum where they have over 100,000 patients who are on there looking for help and advice, and they've got a lot of experience of understanding patients' issues. And then other newer organisations like the Improving Thyroid Treatment Campaign Group, which is a Facebook group, which has been very, very proactive, and we've worked so very hard with them on some of the advocacy work that we've been doing with Thyroid UK and BTF, and also thyroid patient advocacy. So the fact that we're all working together, I think, has made us a voice that people are starting to pay more attention to than perhaps they were a couple of years ago. We've been able to publish a couple of reports together, which we've put all of our logos on, and we've got some good relationships with some parliamentarians and opportunities to develop more, which I feel sort of optimistic that we have made a bit of an impact already collectively, and that we've got a chance to do a lot more. So yeah, today's a chance to reflect on what we have done so far and get some perspective from our guests who come from a more established, much larger organisation. So really, really grateful to the two of you for doing that, and really grateful to everybody else who's joined the call, because obviously we're always looking for more people to get involved in what we're doing. I'm our sole member of staff. I work 2.5 days a week on this. I'm run ragged with all the things that we're doing. So we really need people to kind of offer their time if they can, and their expertise if you feel that you've maybe got professional skills that could be put to good use. And we're hoping that, you know, you might have good ideas and things as well, but particularly looking for help. So for those of you who don't know, I'm going to briefly explain a particular issue that we and our partners have been working on since we started, which is the T3 situation. So we talked a little bit earlier about the fact that hypothyroidism is the most common thyroid condition. It's an underactive thyroid. It slows you down if it's not producing enough thyroid hormone. And usually, we're told most people who have an underactive thyroid are relatively easy to treat. And that is probably the main reason why many doctors simply think that an underactive thyroid is easy to treat, and don't always have a lot of time for patients who perhaps don't respond very well to treatment, which is completely unacceptable, and we're not having it, and we're determined to change things. Some patients respond very, very well to a specialist treatment, which is called T3, liothyronine. And that's another thyroid hormone. It's actually the active form of the thyroid hormone, which if your thyroid is working perfectly, it will produce itself. If you're somebody who responds well to the standard treatment, it will be able to make it from levothyroxine, which is the storage hormone, if you like, that people take. But as a generic medicine, synthetic liothyronine, or T3, has been around for decades, and it's always been known by some clinicians and by patients who've had the experience for themselves that it can be absolutely transformative. It can really, really change people's lives. And we talked earlier about the one example of one of our partners who had really sort of no quality of life at all, and has gone on to establish and run a successful business employing other people. We have lots and lots and lots of stories from patients like that who found T3 an incredibly effective treatment for them. And unfortunately, partly because not very many people have been prescribed it, perhaps because thyroid patients haven't had as much of a powerful lobby as you would expect them to, given how many people are affected by thyroid conditions. There haven't been fantastically clear guidelines about when and how T3 should be used. So not very many people have been prescribed it. And lo and behold, the one company who had a license to market it in the UK up until 2016 increased the price over a 10-year period in incremental steps, until it had increased from less than £5 a packet to more than £250 a packet, which is a 6,000% increase, which has been absolutely horrendous for patients, because that has led to a number of local commissioning bodies, clinical commissioning groups around the country, saying to doctors, oh, you know, we don't really want you to prescribe this because it's very, very expensive and there's not much evidence that it's effective. Situation made worse by the fact that liothyronine T3 was included on a list of medicines that the NHS put out for consultation, to suggest that perhaps they shouldn't be routinely prescribed as part of a cost-saving exercise called the Medicines Optimisation Programme. Now, that consultation ran for a period of time, and many patients and patient groups, and also many clinicians and people like the Patients Association submitted really robust submissions to that consultation to say why it is a vital treatment for some patients. Unfortunately, at the end of the consultation, NHS England did acknowledge that it is an important treatment for some patients, and that it should be made available, providing it's initiated and monitored by a specialist, for those patients who require it. But unfortunately, I think the NHS, being what it is, it's a big, unwieldy organisation, and you know, the message just hasn't been as high profile as it should have been. And so even to this day, you still have a number of clinical commissioning groups around the country being really, really draconian about access to this treatment. And for those people who need it, it's been an absolutely horrendous situation. So there are patients who have been told by their NHS doctors that they, yes, they do need this medicine and their doctor will continue to monitor them, but actually you've got to go and source it yourself, which is just unbelievable. You know, people in some instances are traveling overseas and buying this medicine from pharmacies where in some countries it's actually available over the counter and not very expensive. It's just in the UK that it's very expensive. Some people are buying it online. A lot of people are going to private physicians and being given private prescriptions, which of course you can only afford if you have a relatively high income, or there are people who are doing that who really can't afford it. And who are, you know, being put into, you know, serious financial hardship as a result of having to do that. It's a horrible, horrible, horrible situation. In 2018, there were debates in both the House of Commons and the House of Lords about this issue. And this was just about the time that we were kind of starting to come into being, if you like. And we produced very, very detailed briefings for parliamentarians about why this was a really important issue, and quoting evidence and quoting the British Thyroid Association, which is as we said before, the professional body for thyroid specialists. And we were really pleased that when those debates took place, both of them, the people who spoke in the debates were repeating the things that we had put in the briefing as part of their speeches. Our patron, Lord Borwick, who has thyroid eye disease himself, spoke from personal experience, but also shared a lot of the evidence that we had given him. Lord Hunt, who called the debate in the House of Lords, phenomenally well informed on this issue as a result of patient advocacy work. And the result of that debate, which took place July 2018, the second of those debates in the House of Lords, was that the then Minister for Health in the Lords, Lord O'Shaughnessy, stood up and said, clearly this situation is intolerable, and I will ask NHS clinical commissioners, which is the body responsible for all of the clinical commissioning groups, to tell the clinical commissioning groups that this medicine should be available for those patients who need it. And we were delighted. We came out of that debate. I was there with Lynn from Thyroid UK and Kath, who's now working with the British Thyroid Foundation, and the three of us came out absolutely delighted. And what then happened was that the announcement that the NHS clinical commissioners put out to the CCGs was not that clear, and didn't help our case as much as we expected it to. And so we continued to have a battle on our hands to get this seemingly simple message across. Lord O'Shaughnessy asked the patient groups to produce a dossier to show where across the country clinical commissioning groups were not following the national guidance that they should have been following. And perhaps rather foolishly, I put my hand up and said, oh, I'll project manage that work. We're working with all our partners now, and I've professional experience that might be helpful. I used to be a publisher. And I thought there was maybe going to be about 6 weeks' work, because we'd all been gathering patient stories and we'd all been gathering research, and we had the relationship with the British Thyroid Association, who said they would be our medical advisors. And of course, it wasn't 6 weeks' work at all. I'm a complete fool. It was 6 months' work, and everybody who was involved with that put a huge amount of effort into it. There were lots of drafts. I was at the European Thyroid Association conference in September 2018, and the president of the British Thyroid Association, Professor Chatterjee, and Dr. Carla Milan, who's sort of his second in command there, were there, and they were turning around approvals for things in between conference sessions. It was extraordinary, and we reviewed as a group of patients over 100 different documents from different parts of the NHS that were policy documents or guidelines or information sheets for patients about T3, about liothyronine. And a very small percentage of them were in line with the national guidance. So we produced this sort of table of all of the different CCGs and all of the different issues with all of the different documents. It was a really robust and solid piece of work, even though it wasn't conducted by academics, it was conducted by us. I say us, all of the patient groups working together. We also heard from over 400 patients sending stories to different patient groups. And this was the beginning of the thyroid patient registry that the Thyroid Trust have been putting together, because all of the patient groups were hearing from patients in different ways. And what we did was we developed a form where people could basically answer a series of questions that then puts their story into a database. So voila, we have a registry. And that registry includes the year that people were born and the age they were that they were diagnosed, and permission for that data to be used by researchers, and permission for the data to be used anonymized in publicity. And we have people's contact details, but obviously we keep that separate from the data so we can go back to people and get updates or ask them if they want to be involved in publicity. So that patient registry now has over 70 stories, and if anybody's interested in submitting their story, if you haven't already, to the patient registry, you can go to the information pages, submit your story on our website, and we'd be delighted to have your story. We don't have the resources at the moment to provide people with individual support, unfortunately, because we're just too small, but we'll get there, and I think having that data is really useful. One of our trustees is used to be the research manager at the Association of Medical Research Charities, and he's confirmed that that has some research value. And the next stage for us with that is to find an academic or researcher to work with to codify that database. But it's such a slow process, and as a small organisation, we're doing so much else as well. So it would be great if anyone was interested in getting involved with helping with that, maybe approaching academic institutions, showing them what we've got, and sort of getting somebody engaged. This social studies grant that you mentioned, Brooke, was something that I didn't know about from the NIHR. It would be great to be able to access some funding from that and get somebody who's interested in this issue to work with that data. So for the dossier, we had over 400 patient stories. Some went into our registry, some were submitted to other patient organisations. We chose a selection of those, and if I'm remembering correctly, I think we had about 18 stories, really, really powerful personal stories that showed the human impact of this issue with liothyronine. And we submitted it to the Department of Health and Social Care and also NHS England in November 2018. Gosh, lost in space with when things happened. And within days, NHS England published new guidance on prescribing liothyronine. And clearly, it hadn't been produced taking our report into consideration, because it came out within days of the report being published, and it would have taken several weeks or months to be produced. And we weren't happy with it at all as a patient body, and there was still lots of the errors that we'd highlighted in the and along with NHS clinical commissioners as well, got some senior people in the room with the support of our patron, Lord Borwick, and also Lord Hunt, who's become, as I say, increasingly involved in this. And we held it at the House of Lords, and it was quite a high-level discussion. And they agreed to revise that guidance. So that was a really big deal in terms of advocacy work. A huge amount of work had gone into having this document to put in front of them and say, you must take this seriously. And they did take it seriously. So in July 2019, that guidance, which had been published in November, was updated. And again, we had worked very, very closely with NHS England on a number of drafts, putting the patient perspective across very strongly, but obviously, having to do that in a very, very professional way, because to be able to have those conversations, you have to speak their language. So the new prescribing guidance, which came out from the Regional Medicines Optimisation Committee, is prescribing guidance specifically. And it says what we would want it to say, that if a patient has not thrived on levothyroxine alone and an endocrinologist recommends that they should try liothyronine, it should be prescribed on the NHS. And if they and an endocrinologist are satisfied that it is resolving their symptoms and has restored their well-being, they should continue to be prescribed on the NHS. So we were very happy about that. But we know that because it is a new document about just one medicine, and the NHS is dealing with thousands and thousands and thousands of medicines in different conditions, and perhaps my cynical self says perhaps some CCGs are still very concerned about the financial side of things, and the cost hasn't come down very much. We know that lots of CCGs are still not allowing doctors to prescribe this medicine, and lots of patients are in really, really dire straits. I'll just say something about the cost. We had a meeting with the original license holder of that medicine, again with our patron Lord Borwick, and you know, they gave us their reasons for why the price had increased from their perspective, and you know, who knows the ins and outs of it all, but we were really sort of reassured by the Department of Health and Social Care that the price should come down when they brought more manufacturers into the market. So there's now 3 companies selling liothyronine, and the price has come down, but it hasn't come down very much. So there's a law which was passed, the Medicines Act in 2017, that should allow government to intervene in prices of generic medicines that are too high, and that just hasn't happened yet. And I think we would all agree that we feel that Department of Health and Social Care seem to be sort of moving very, very slowly on that. And we really need to put some effort into talking to them. For those who are not aware, the Competitions and Markets Authority are investigating that company who were originally the sole licence holders for liothyronine, and they have been found provisionally guilty of abusing their market position. And if they're ultimately found guilty, they're facing a fine of 10% of their global profits, which would be huge. But we're sort of getting a lot of intelligence telling us that process could take many, many years, that pharmaceutical companies have very deep pockets in terms of defending themselves from legal action, and that, you know, they may well be able to put a case forward which defends their position, and that might not happen. The Department of Health and Social Care have said that they're going to undertake a consultation this year with the public on the generics Medicine Pricing Act. So I'm hoping that things might move more quickly than waiting for the CMA investigation, but it's, who knows. I think now that we have relationships with the likes of Healthwatch England, which I'm coming on to, more people who really sort of know how this kind of thing tends to work, we can maybe get more guidance, but we need more authoritative voices involved in this as well. So we keep pushing. Where was I? So yes, no sooner was the Regional Medicines Optimisation Committee guidance published than hot on its heels came the new NICE guideline for thyroid disease assessment and management, and ourselves, and again all of the other thyroid patient organisations, and of course the thyroid specialist professional body, spent a lot of time and energy in submitting evidence and comments on that guideline as it was developed. And there were some good things that came out as a result of our interventions in the NICE guideline. So the NICE guideline now says very explicitly, which it didn't in the early drafts, that if a patient is not restored to well-being when their blood tests are in normal range and they are taking levothyroxine, that the GP can consider adjusting their dose. Now it seems like a small thing, but actually it's a really big deal. I know, you know, I didn't feel well on levothyroxine alone, which is all I take, until my TSH was very, very low. And I had several dose adjustments, and I'm now on a very finely tuned dose of levothyroxine. So we know that in some cases, a dose adjustment can make a really, really profound difference for patients. So we were really pleased, punch the sky, that message actually got into the NICE guideline as a result of all of our efforts. And another thing which is so, so important and shockingly wasn't in early drafts was the fact that doctors should be treating patients not just on what their blood tests say, but also on how they feel, that patients' symptoms should be taken into consideration. And it seems crazy that should be such a difficult thing to have included in the NICE guideline, but we did manage to get it in there, so we are really pleased about that. But the big problem is that T3 is hardly mentioned in the guideline, and their reason for that was that NICE will only look at large-scale only look at randomized clinical control trials, and large-scale trials have not been done on T3, and the small-scale trials that have been done, if looked at collectively, are simply inconclusive. NICE guideline does refer to the NHS England, the Regional Medicines Optimisation Committee prescribing guidance, which means that they support that guidance. So if anybody is being told by their doctor or by their clinical commissioning group that NICE does not support prescribing of T3, that is incorrect. NICE does support the the prescribing guidance that NHS England issued through the Regional Medicines Optimisation Committee. And the key thing with the NICE guideline is it's not meant to be comprehensive. It's not meant to replace clinical judgment. So those are sort of key messages that we're trying to get across through our communications for patients to be really aware of, that just because NICE doesn't address this specialist treatment doesn't mean that doctors should not be prescribing this specialist treatment when it's required. We've followed up the NICE guideline and also the liothyronine dossier with a subsequent report, the T3 prescribing survey report, which was led by Thyroid UK, which we worked very closely on as well. We helped with the executive summary in the report, and that basically shows that across the country, at least 46% of CCGs are still restricting access to T3. And we have a real job in our hands to use that new report as leverage to bring about change. We're having follow-up discussions off the back of publishing that report, again with NHS England and NHS clinical commissioners, and we've now brought Healthwatch England into the discussion as well. And the most recent meeting that we had with them, again at the House of Lords, hosted by Lord Borwick, NHS England said that they would contact CCGs and reiterate what the national guidance says. But of course we now have COVID-19, and all of NHS is utterly focused on that. One of the speakers we were meant to have today, Genevieve, works for the NHS, and everybody in the NHS is wholly focused on that. So I did speak to our contact at NHS England this week. He was kind enough to give me a little bit of time on the phone, and he did say that the letter, which is going to be sent out to all of the CCGs, it has been started, but it's all parked to one side at the moment. So we're going to have to pick that up when things with the pandemic are a bit more under control. One of our fantastic volunteers, Helga, has been working on looking at all of the MPs who have said anything about liothyronine since all of this began. So we've now got that as a database of stakeholders to approach. Obviously we can't at the moment because we're just not going to get any airspace, but we hope that we can get those people sort of more on board, not just in a sort of ad hoc, disparate way, but really sort of behind the organisations. And I was lucky enough to attend an event with Lord Borwick at the beginning of this month, where I met another peer who suggested to us that we should have an all-party parliamentary working group, and gave us some direction about how we could go about making that happen. And I know that's something that's been tried before, and it's not been possible to get MPs interested, but I'm hoping that, you know, we can revisit that and maybe make that happen. I feel that I've been talking for too long and I've said too much. There's so much happening, there's so much to say. Hopefully that gives you a bit of an overview of what we've been about. I mean, we've also been doing things like attending professional conferences, European Thyroid Association, British Thyroid Association, the Thyroid Eye Disease conference in Pisa, and the British Thyroid Foundation NICE conference. And we had some training with the European Working Group of Cancer Patients in Frankfurt last year. And through our memberships of international umbrella bodies like Thyroid Federation International, Thyroid Cancer Alliance, we're getting access to these sorts of events, and really we want sort of more volunteers working with us that we can send to those events that can be representatives for thyroid patients, but also to sort of build our collective knowledge, because there's so much that you can learn and you can really develop your network with clinicians. And we're doing things like fundraising initiatives. We do need to raise more money to carry on doing what we're doing. It all feels a bit precarious at the moment as a very new organisation. We need to build the team. Quality control and good governance over what we do is really, really important. It can slow us up. It's difficult stuff. But I think we are making progress. And huge thanks to everybody behind the scenes who does so much, and people who are starting to get involved now as well. We are very stretched from capacity wise, but I think it will get easier over time. And if anyone's in a position to make a regular time commitment, feels that they've got skills that they can offer, we really want to involve them as much as possible.